Dr. G. Vijay Kumar, I request you, sir, to please go on to the stage. May I, on behalf of everyone here, request Dr. V. Rajendran, the Chairman of the Organizing Committee of TRAC 2025, to read out the citation, please.
Good evening, one and all. I think this is the second TRAC meeting where the chairman's oration is happening, and I was privileged to give the first oration. For TRAC 2025, the chairman oration is going to be given by Dr. G. Vijay Kumar. The Tamil Nadu chapter of Rssdi has the privilege of welcoming Dr. G. Vijay Kumar, the current chairman of Tamil Nadu chapter of Rssdi, to deliver the TRAC 2025 chairman's oration. Dr. Vijay Kumar is a distinguished diabetologist with over 4 decades of service in patient care, teaching, research, and professional leadership. He is a graduate of Sri Venkateshwara University, Tirupati. He specialized in diabetology at the University of Madras and further trained at the WHO Center, University of Zagreb. He is the founder and director of Diabetes Medicare Center in Chennai and serves at the Apollo Specialty Hospitals and St. Isabel's Hospital. He is renowned for his evidence-based, patient-focused approach. He has touched thousands of lives through compassionate and effective care. Dr. Vijay Kumar has held key positions in Diabetes India, the Diabetes Association of India, the Research Society for Study of Diabetes in India, and the International Diabetes Federation. He has organized major scientific events including the World Congress of Diabetes India 2015 and the Rssdi Golden Jubilee celebration in 2022, and continues to lead high-quality CME programs and workshops. His academic contributions as faculty from WHO, WDF projects, member of the Senate at the Tamil Nadu Dr. NGR Medical University, and joint editor of the Asian Journal of Diabetology, have advanced diabetes education across the country. Among his many honors are the Best Doctor Award from Tamil Nadu Dr. MGR Medical University, the Blue Ring Award from the International Diabetes Federation, the Ugadi Puraskar, the Sudigali Award, and several prestigious orations. In recognition of his exemplary leadership, lifelong dedication to the advancement of diabetology, and his outstanding contributions to patient care, research, education, and professional service, the Tamil Nadu chapter of Rssdi is privileged to confer upon Dr. G. Vijay Kumar the chairman's oration at TRAC 2025 with deep respect, sincere appreciation, and warm congratulations.
May we request the speaker, the oration speaker, request Dr. Balamurugan, the Secretary of the Organizing Committee of TRAC 2025, to adorn the doctor with a shawl. The speaker. May we request Dr. Bavadarani to kindly adorn him with the medal. And may we request Dr. C. Muralidharan to give the memento. The citation will now be handed over by Dr. Rajendran.
I'm really overwhelmed with the honors that I got. I'm never expecting this to happen to me. Thank you, my colleagues in Tamil Nadu chapter of Rssdi. And it's more than honor, it's more of an affection and recognition. And I would like to say one thing about the Rssdi Tamil Nadu chapter, is that when it comes to matter, all of us are together. And there's the biggest quality that we have amongst our diabetologists, physicians, and endocrinologists, whoever it may be, a part and parcel of Tamil Nadu Rssdi. I'm very happy to be with here actually. Now, I also, at the outset, I would like to congratulate our organizing secretary of the conference, Dr. Balamurugan, and Chairman Dr. Rajendran, for effectively and extremely good conference today. And I know how difficult it is to make a meeting, definitely. And I would like to also thank especially Dr. Shanmugavelu, Dr. Balaji, and Dr. Muralidharan to pushing me to become a chairman. And it so happened it's unanimously elected. That indicates that the love and affection that everybody has got for me. And I would like to thank for everything. as far as the oration is concerned, I thought diabetes in India and challenges and solutions. Whatever I faced during my 37 years of practice in diabetes. So, but there are challenges are too many, but the solutions are not easy to implement. That's what we face in our day-to-day practice in diabetology. Now, the worst challenge that we are going to have is that the Indian scenario for diabetes, we have 10 crore diabetics and then about 13 crore pre-diabetic patients. So total about 23 crore people with dysglycemia. That is the ICMR in-depth study is created. But look at this, the mean HbA1c of all our people with diabetes is 8.9, and only 1/3 of our patients are having a good control of less than 7, and 2/3 are yet to be under control. Now, this is another interesting study by Dr. Ramchandran et al. What they have shown is that when somebody is found to be clinically diagnosed with diabetes, the HbA1c is about 9.1, and while before diagnosis it's over diabetes diagnosis, and they are screened for diabetes, the HbA1c has been 8.3, indicating that the moment they have found to have diabetes does not mean that it's come overnight, and there is a long delay in diagnosing diabetes as well. So they had asymptomatic disease quite even before getting into that. That indicates that they more than almost 1 HbA1c indicates that probably we have to screen more and then detect them early, because you could see here in our diabetics there are so many 10 crore population with over diabetes, but there are so many people who are undiagnosed with diabetes. I think screening plays a major role so that we can screen them early and diagnose them early, and so that effectively treat them early. This is one challenge. Now, what I also faced is this is a unique way of looking into an Indian phenotype of a diabetic. We are different. Our diabetics are different compared to other populations. You could see that the Asian Indians tend to have earlier onset of diabetes, at least what it is said to be that at least 1 decade early compared to other races. And then you can see that longer duration of diabetes and lower BMI with a high waist circumference and high fat percentage. They're entirely different. The same BMI, what we have the fat is something a lot, especially the waist circumference, and ectopic fat and visceral fat is very, very high. And also we have a problem of higher triglyceride, higher HbA1c and a lower HDL when compared to the Europeans and others. So we are a unique population of diabetes, and I think that is the reason it's a big challenge that we have to follow so many guidelines, but that's not sufficient. We need to adjust these guidelines whatever we learn, say from Rssdi guideline recommendations or ADI, whatever it is, whatever you follow, IDF, whatever you follow, but they need to be adjusted to our type of population, and that's a big challenge that we have to think about. And then another study which has come is that according to the Lipid Association of India criteria, it is said that the 40% of the people are classified as high risk and 60% are classified as very, very high risk. So you could see that almost nobody is non-risk patient, and that is to be kept in mind. The reason is that there is no such thing called mild diabetes or severe diabetes, like something like a pregnancy. There is no mild pregnancy or severe pregnancy. Similarly, diabetes is diabetes, and we need to look into that. And I think people should also understand that every patient is a high risk patient, and we need to take care of them holistically. Now, this is what happened when a long time ago Hafner et al. Has said that mere presence of diabetes is equal to cardiovascular disease. That's what he said about almost 3 decades ago. Now there is another problem what we have. If you look into that MASLD, that of fatty liver, worldwide incidence is 25%. Look at India, it's 38.5%. It's almost 20% more than what we can think about. And then you can see that the most important thing is that pediatric age group of people, they are going to have a lot of fatty liver amongst them. And And apart from this, we can see that the microvascular complication in the form of DKD, diabetic kidney disease, recently published site study, which I am also part of it actually. We found that 35% of them had got DKD in our population, and then the risk is associated with long duration of diabetes, higher HbA1c, male and non-vegetarians. This is what we found in that site study, and indicating again that we should not, we need to control diabetes as soon as possible so that we can reduce the incidence of DKD as well. And this is another problem. Apart from microvascular complications, the challenge that we have is that 1/3 of our population in type 2 diabetes have got symptomatic cardiovascular disease, and we investigate, there is another 1/3 of the people who found to be having asymptomatic heart disease. So it looks like that about 2/3 of our population are having either symptomatic or asymptomatic cardiovascular disease, and this is again a big challenge that we need to face. And then why I am trying to say is that it is very essential for us to look into these aspects, and so that what we can do is that we can design our treatments towards that, reducing that. And no doubt why the Ministry of Health and Family Welfare have committed that we need to reduce as much as possible the deaths that can happen with NCDs, that is non-communicable diseases, because nowadays the infection rates have come down, and all the other things have come down, but NCDs are increasing, and we will find out why this is happening. NCDs are increasing, and then why we need to look into reduction. This is not a small challenge, it's a big challenge again. Now if you look into solutions, probably for all the microvascular complications and macrovascular complications that can happen, what we need to have is a holistic approach towards diabetes. It's not just enough to have a good just control of diabetes. Only the best control of diabetes and control of lipids and hypertension should be there. And most important thing is emphasis on lifestyle modification, which we usually our patients doesn't do. And then awareness amongst our patients and healthcare professionals about all the problems that they are facing and the solutions that we can give. And then regular follow-up by the patients. We need to educate them at least once in 3 to 4 months they have to come. This is again, if we can do that, if we can assure that they are coming for follow-up, we can do a lot of things for them, because we know that diabetes is a progressively deteriorating disease, and then we have to change our strategies over the time, each time they come. And that is the reason we should be ensure that, because they may be asymptomatic, but that is the reason they may not come back to follow up. But we need to ensure that we have to have a regular follow up. Screening of diabetes, and also screening to detect early the complications and try to reverse, especially the microvascular complications, reverse or slowing the progression of the complications is a big duty that we have to have. And in that way, I think morbidity will come down. And most important is where India, we are a pocket-friendly nation, and then for all these things that we need to have, we need to select a cost-effective therapies so that patients will adhere to the disease, to your prescription. In that way, I think IDF Global Type 2 Diabetes Clinical Practice Recommendation just recently, about a few months ago, which has come down, that very clearly said that there is a division between optimal care and basic care. Optimal care is best therapy that is available when cost is not an issue. And basic care is the one where we can see that we need to select the drug so that the cost will also come down. Now, for example, apart from that, we can see that we can go for metformin and SGLT inhibitors and DPP4 inhibitors, which are now quite economical in our country, thanks to that. And then we are in a best period where we got therapies for even complications reversal as well, and at an affordable cost. And that is what is the best thing that is happening. Now, we look into that, the people who have got no complications or low cardiorenal risk, and with cardiorenal risk, we can see that in optimal care, we have an expensive drug such as the GLP-1 receptor analogs, and we have even SGLT inhibitors. Whereas if